Yeah.
Good, good. So, yes, this I think is our 25th or 26th update seminar. And I really, every time I prepare for one of these seminars, I think how far we've come in just over 2 years in learning more and more about COVID-19 and its ramifications. So as we usually do, we'll start with an update of coronavirus around the world, and we've selected some countries. We will hear more from about the United States from Sonia later on. However, the number of cases are dropping, and this is from one of the Johns Hopkins reports. Basically, the viral circulation is going down, and this is good news, and there are several reasons for this. We cannot say that it's the same everywhere, at least not everywhere in the world. This is our dashboard with the number of cases, and you will see that we are up to over 500,000 infections, which is largely, most probably an underestimation. We have had over 6 million deaths, and to date we have administered over 11 billion doses of vaccine. So, and this was done in just over a year. So I'm sure that you are aware of what an endeavor producing and deploying this vaccination campaign has been. My screen seems to have frozen, so this is not good news. I don't seem to be there. The first country that we have looked at is South Africa, because there's been a lot of talk about South Africa. We know that this is where the Omicron variant emerged. And South Africa is a country that is very active in surveillance compared to the rest of Africa. And in fact, it is the country that has had most cases and deaths in the African continent. But this is most probably due to how much diagnosis and surveillance they do, and how extensive their surveillance is. However, South Africa may be entering the fifth wave, and there have been recently, there has been the emergence of two Omicron subvariants, BA4 and BA5, and we'll talk about these a little bit later on. They are evolutions, they're viral evolutions of the Omicron variant, and as far as we can say, they do not cause more disease. In China, you might have heard that there's been an outbreak in the Shanghai area, and in China, they have a zero COVID approach. So their approach is to nullify viral circulation. So as soon as they find an outbreak, they immediately quarantine the people who are infected to stop that viral circulation. And given the densities and the number of people infected, there was this large quarantine effort. Over 4 million people were forced to stay at home and could not leave their house. At the moment, it seems that this very extensive and rigid quarantine has worked, because there are currently no cases outside of Shanghai. Brazil, as we know, was a bit slow to catch on with the vaccination campaign, but now more than 3/4 of Brazilians are vaccinated, and the country is easing the restrictions on travelers. and all you need to do is prove that you're vaccinated. And of course, life wants to be back to normal with the carnival celebration back after 2 years. Now, in the United States, these are the numbers that we have. We have 81.2 million cases with 92,000 deaths, 992,000 deaths, which is nearly a million deaths. And there was a recent study which was talked about very much that, let's say, proposed or that reported that there were infection-induced antibodies in 58% of the US population. And this is a very high number if you think about it. Luckily, at the moment, thanks to the seropositivity by natural infection and by vaccination, cases are mild and hospitalizations remain low.
No,
However,
never mind.
we spoke about the two South African subvariants, BA4 and BA5. They have been detected in the United States. What is happening in Europe? Europe has basically declared the end of the emergency, and let's say, the slogan at the moment is this disease should be treated similarly to influenza, which means that you should be aware that every year there will most probably be a new vaccine that is available with updated variants, and that this vaccine should be administered first to people who are at risk and then to the general population. There is no need to quarantine, and masking policies have vastly been lifted. Only some European countries, they still require masks, for example, in public transport and in some situations, but generally speaking, all the restrictions have come down. And also the approach to the disease has changed, because previously we had these testing programs which wanted to identify every case. Now, this is not necessary anymore because there's no quarantine and the virus is becoming endemic. So they have declared the end of the emergency. So we mentioned about variants and sublineages, and I want to mention something that we spoke about in one of the previous talks, at one of the very early talks, the difference between a variant of concern and a variant of interest. So these viruses mutate and they evolve over time with different mechanisms. And so they are constantly evolving, and they will not be the same, as the original virus, or as the viruses that we have now will not be the same than the ones we have in 5 years' time. Now, a variant of concern is a variant in which there is evidence of some sort of increase in transmissibility or more severe disease, or there is a change in the capacity of this variant to be neutralized by antibodies raised against existing vaccines. And that is a variant that concerns international organizations and that need to be looked at more closely. There's another, let's say, a subset, which is variants of interest. Variants of interest are like the precursor of a variant of concern. So not all of the variants of interest become variants of concern, but some of them do, and they are at the early stages of the changes that will bring these variants to become variants of concern. So when is a variant considered a variant of interest? When it is associated with changes to the receptor binding, or there's a reduction in the neutralization generated by antibodies by previous vaccines. But so there is a potential there rather than an evidence of the variant being very different from the other circulating strains. Now, the reason why I bored you with this is to show you where we are with the variants of interest and the variants of concern at this time. So currently, the variants of concern are Delta, Omicron, BA1, and BA2. The variants of interest that we have circulating now and that we are keeping an eye on are Omicron, BA4, and BA5, which are the ones that were also recently found in the United States. However, both of these variants, as I mentioned, do not seem to have to create a more severe disease or have an impact on immunity. There is this Omicron subvariant, which I will not spell out for you, which is now causing 1 out of 5 infections in the United States. The Omicron cluster of viruses seem to cause a very similar disease. And of course, what is happening is there where the warmer weather is approaching, there is a lower risk of transmission. And this also justifies or explains what we have seen earlier, that there's a continuous decrease in the number of cases. I would like to mention and show you a few numbers about vaccination. We have, this is where we are with the vaccination campaign. We've seen 11 billion doses have been administered, and I think it's quite clear where they have been administered from this map. And this is one of the, it's the, I think, biggest preventative effort that has ever been made in history. Here are the numbers that I wanted to, excuse me. Here are the numbers that I wanted to mention. 11 billion doses administered worldwide, over 184 countries. And the numbers, we are administering worldwide 30.2 million doses every day. Now, I thought that we would mention something about boosters, because the time is coming and a lot of us, we ask ourselves whether we should have the booster, when should we have the booster. Here are, there's a quote from Dr. Fauci, who pushes Americans to think that this will require booster shots and it will become an annual vaccination, as we said, very similar to the flu, to the flu shot. There's a lot of talk. There's a lot of talk also internationally about when to boost and how to boost and what products to use. However, the consensus is that we will need to have periodic immunizations so that we can keep people out of hospitals and viral circulation low. There is an interesting finding with a treatment, this oral antiviral treatment, which was developed to treat COVID-19, was used to try and prevent symptoms in people who were exposed to COVID-19, and it did not succeed. So it is not active as a preventative drug for symptoms. So they basically they administered it to people who were exposed, and then they went to see how many got sick and how many didn't. and there wasn't a big difference. Another bit of news is that another drug, which is a drug that we know about, which is remdesivir, has been its use can now be has been expanded to include children who are older than 28 days and weigh more than 3 kilograms. And Sonia might want to comment this about how this drug works, but at least it's been licensed and has been approved for children. A few words about long COVID. Long COVID is a great concern, I think, for a lot of us, and certainly for health authorities worldwide, because from 10 to 30% of cases of people who've been exposed to COVID, they get long COVID, and this has many different ramifications. At the moment, what is trying to be done to treat long COVID is look at monoclonal antibodies that can reduce the symptoms by boosting the immune response. In earlier studies, immunosuppressants were used, but they at least didn't seem to succeed in some cases, in certain cases, and so they have tried this other strategy as well. During this series of talks, we've spoken a lot about fake news and misinformation, and I think that now we should all be aware about how dangerous and how much damage fake news can make. And there's a very interesting study which has been published in one of the Nature journals on how certain websites, by generating social media material, have basically flooded the infosphere with misinformation, and how this has resulted in vaccine hesitancy and refusal. So they have also identified some of the websites, and you can see that there is certainly this first website up here, Children's Health Defense, that is incredibly influential and has produced enormous amounts of tweets, I think they are, to promote vaccine hesitancy and loss of trust in institution and in institutional messages. Going back to misinformation, as I said, can really do some terrible things. And there's this article, which it was actually on NPR, and it tells a story of how a woman had believed and had actually convinced her family that of all sorts of falsities, like that the vaccines contain microchips and that they were being used to spread COVID and so on. And this woman her whole family was hospitalized, and she refused to take treatment, and she died. And so this article talks about the daughters and the family of this woman, analyzing how these conspiracy theories have actually caused this woman to make all the wrong decisions and therefore die of COVID. And so, as if COVID didn't create enough problems by itself, the whole misinformation domain is something which will probably be a large area of study in the future. A few words on mental health, because there's been an interesting study in Australia. Now, Australia implemented a very severe lockdown. They also tried to have a COVID-0 approach. And basically, you can see the numbers here. There's been an increase in people calling for psychological support. There's been 264% increase in cases of kids seeking for psychological help, and also eating disorders are on the rise. So we will, as the pandemic continues to unravel and its ramification and consequences also continue to unveil themselves, we will see more and more of these studies and more of the relations between mental health and the pandemic, which includes the virus, but also includes all the policies that were put in place to manage the emergency. An interesting observation is that China, which is a country which has never paid a lot of attention to mental health, is actually now, with COVID, becoming more and more aware of how the population is suffering, and awareness about issues around mental health are rising. And pandemics are transformational events, and they can also maybe sometimes bring, actually they do bring good transformation. As usual, we close with animals. We know that there is a very critical situation in the United States with hundreds of deer that have tested positive across 24 states, and the virus has been, it was obviously acquired from deers, to deers from people. However, there has been also a reverse spillover, and the concern is that in these wildlife populations, there can be this parallel circulation of viral populations that can create new variants. Here are the species that that have been reported, the animals that have been reported, and I would invite you to look at the geographical distribution. It seems that obviously, it's quite obvious that a lot of the outbreaks in animals have been picked up in Europe and the United States and South America, and very little in Africa, which is really strange. And so we hope that surveillance in certain parts of the world in animals increases, so that we can understand how the virus is circulating in animals and how it is, because this represents a threat to the health of animals and because of reverse spillover to people. There's been this other interesting paper in Nature that looks at spillover events over the next 50 years. They made a sort of like an estimation of how many spillover events we can have, and over the next 50 years. And the results of this study say that over 4,000 spillover events could occur in over 3,000 species. And these are linked, of course, to climate change and other environmental dynamics as well. And so we know that pandemics emerge from spillover events that are quite rare events, but maybe they're not as rare as we think they are. And certainly their number could increase because of other changes that are happening in the biosphere. And so this brings me nearly to my last slide. We know that one of the things that is extremely important in preventing spillover is not to mess around, I would say, with wildlife. And so stop wildlife trade, stop the consumption, and invading the spaces to stop pandemics. And yeah, we have a little surprise, which is knocking on our door, which is, you have probably heard that there's avian influenza all over. Well, it's quite widespread also in Europe, but also in the United States. There's been several states that have been affected with millions of chickens dying. And this H5N1 virus, which has infected these chicken farms, has infected also a person who was working on the farm and was depopulating the farm because of the outbreak. And it was not a severe case. There was only fatigue, and he was treated with an antiviral. So we have to be aware that we have a series of situations that are at risk for spillover events, not only from bats, but also from birds and from many other animals. So this brings me to this last slide, and we would like to wish you a nice summer, the whole One Health Center, of course, but I wanted to make a couple of announcements, and both announcements, they make me they make me sad, and I'm also happy, and so mixed feelings, as we say. So first of all, my pal and the person who has been with me all this time and has, been absolutely instrumental for the success of these talks. We've reached thousands of people, and Sonia Rasmussen is leaving UF. She will be leaving in July, and so she is going to Johns Hopkins. So that's very, very good. It's good for her. I'm happy for her. And but I'm sad for UF, and I'm sad for One Health, and I'm also sad for all the One Health friends that have benefited so much from her talks, from the lectures that she's given, and of course that have benefited from her expertise. So this makes me a little bit sad. Another little bit of news, which also makes me sad, is that Thomas Field, who is our communications specialist, will leave, and we will have a new communication specialist, Alejandro Sanchez. Thomas has been with us for 2 years and a half. We've been through the pandemic. If this series has been a success, it is also because Thomas has organized it and has advertised it and has made it available on streaming and all the rest. And so he's moving on to a new position, which is very well suited for him, and the whole team wishes him all the best. And thank you for everything that you have done for us, Thomas. And with this, I would like to give the floor to my friend and pal, Sonia Rasmussen. Let me stop sharing. There we go. Sonia Rasmussen for her part of the seminar. Thank you.
Great. Can you see my screen?
Yes, it's not in presentation mode. Perfect.
Should be now. Okay, great. So I'm going to just go through some of the updates since we last met on March 15th. And some of them are related to vaccines, some are related to case numbers. You heard from Ilaria that case numbers are down globally, but we are starting to see an uptick in the United States. Here you can see in May, we're starting to see an uptick again. I think that's not unexpected given the variants that are circulating right now. So Here you can see the different types of Omicron. All of these are all different types of Omicron, kind of sister viruses. This was the original Omicron. Then this was BA2 that we saw kind of take over from the original Omicron. And now there's a BA2.12.1 that appears to have an advantage in the growth and is increasing. And as of this last week was at about 36% in the US of cases that have been tested. You can see there's really no delta left. Here you can see the community transmission in the United States, and keep in mind that these are the new numbers. If you look at the amount of cases, it's actually higher. This takes into account hospitalizations, staffed inpatient beds. It's not just looking at numbers anymore, partly because we realize that one of the things that's really important is number of persons in hospitals. The other thing is we also realize that the number of cases is probably underestimated now, given all of the home testing that's occurring. So you can see that most of the country is green or yellow. Those are areas where masks are not recommended to be worn at all times in indoor places. But you can see there are areas in the Northeast that are back to having recommendations for masks to be worn inside. And you can see especially New York here and parts of Maine. So what about vaccines? Well, this is the slide that I used last time. Of course, we've had an update now that there are recommendations for a second booster for some people. And I just thought, in case you haven't kept up with that, I think it is a little complicated to keep up with who should be getting a second booster. Everyone 12 and above is supposed to get that first booster, and hopefully you guys have all gotten that. Who's eligible for the second booster? Adults age 50 years and older, people who are 12 years and older who are moderately or severely immunocompromised, and then people who got the Johnson & Johnson vaccine. It is important to note, though, that they should not get Johnson & Johnson again. They should get Moderna or Pfizer. So here, if you're trying to decide, if you haven't gotten yours yet and you're trying to decide, you can see here, this PDF walks you through, first of all, are you even eligible? Are you 50 or over? Are you immunocompromised? Did you receive 2 doses of the Janssen vaccine at least 4 months ago? Are you living with somebody that would be really in trouble if they got sick? Can you wait? If you've had COVID-19 in the past 3 months, you probably can wait. And if you feel like a second booster would make you not want to get another one in the fall, you might want to wait to the fall of 2022, because it is expected that there's going to be some seasonality of this virus and that it could go up then. If you feel like you are just as happy to get it now and be protected and get it later, that was the decision that I made, because I'm doing a bunch of travel in April and May, and I wanted to be as protected as I could possibly be. So if you get a second booster, make sure it's 4 months after your last COVID booster. Remember, it can only be Moderna or Pfizer. You shouldn't be getting Janssen or Johnson & Johnson. And you don't need to bring anything saying if you're compromised, you can self-attest. You don't have to bring anything to prove that. So how are we doing with vaccination rates in the United States? Well, for elderly people, for people 75 years and older, you can see 95% have had at least 1 dose, 86% are fully vaccinated, but you can see it really goes down as you get younger. So for 12 to 17-year-olds, only 58.8% are fully vaccinated. And you can see for 5 to 11-year-olds, we have a lot of work to do. 28.4% are fully vaccinated. 35% have received at least 1 dose. So how are the vaccines doing? And this is prevention of hospitalization. And as we've talked about a lot in the more recent talks, the vaccine, although originally it looked like this is great, it really prevents COVID-19, any symptomatic COVID-19. As the variants have come through, it doesn't protect as well. I think that's expected. The original vaccine was formulated for a very particular type of virus, and now there's been a lot of changes in that virus. Here you can see this is for adults aged over 18. You can see the risk of hospitalization. Your risk of hospitalization remains much higher if you are unvaccinated in blue versus if you're vaccinated in green. You can see here that the booster, the third dose of the shot, does provide some protection. So you can see these people here who have gotten the full series plus a booster, their risk is lowest of hospitalization than people who have just gotten 2 doses. And then here are people who are unvaccinated. So you see the big effect that we can have in getting some of those people that are unvaccinated and switching them to being fully vaccinated. We get a little bit more effect on people if they get the booster. Here is for kids 12 to 17-year-old. And here you can see this is fully vaccinated with an extra booster dose. This is fully vaccinated 2 doses. And then here you can see unvaccinated have higher rates of hospitalizations. Of course, rates of hospitalizations in kids 12 to 17-year-old is lower than among adults. And then here's for kids 5 to 11. You can see in kids 5 to 11 that we've continued, as the rates have gone up and down, there continues to be good protection from hospitalization. Not perfect by any means. Again, the rate is lower among that group, but there is protection against hospitalization for kids for 5 to 11 years old. So now I want to talk a little bit. This is the paper that really kind of hit the news this last week about the rates of infection-induced SARS-CoV-2 antibodies. So this is how many people have gotten sick from SARS-CoV-2, or how many people have gotten infected, that's probably better, and have antibodies from it. And this was using commercial lab specimens. So if you'd come to get your blood drawn for hematocrit or something supposedly routine, it was really a convenience sample. It wasn't meant to be trying to get a swath of the US population. It was blood specimens that were collected for something else, but it was in 50 US states, District of Columbia and Puerto Rico. They were able to test for infection-induced antibodies. So we know that there are 2 different kinds of antibodies. There's kinds that are the anti-spike. That anti-spike is what you're going to see if you've had the COVID-19 vaccine. This is looking for infection-induced antibodies. So that's the anti-N or anti-nucleocapsid antibodies. And what they found is you can see Omicron really increased the rate of seropositivity. So here you can see overall in the US, about 57% of people have been, at least based on the seroprevalence study. And as you remember, it's maybe not the ideal kind of study that you want to do. It is a convenience sample, but of these blood samples that were tested, 57% were positive. You can see it's really high in kids, 74 in 12 to 17-year-olds and 75% in 0 to 11-year-olds. Now we know that provides some protection, but we don't know as much about how long it's going to last and how broad it is. It seems to be specific for the kind of variant that you had. So if you had Omicron B1.1, it seems to protect well from that, but we don't know how long that lasts. If you are not asking a question, if you could put your phone on mute. So I also want to talk a little bit about kids. This is a paper about hospitalizations in kids 5 to 11 years old. Because I've certainly heard people say, well, gosh, so many kids have gotten this and it seems to be just not that big of a deal. Why are we making a big deal about this? And I just want to show, for someone like me that's a pediatrician that certainly has taken care of a lot of kids in the hospital through the years, it's a big deal for a kid to be hospitalized. And this shows the 400 kids that were hospitalized in the first few months of Omicron. So kids were being hospitalized. I hear again and again, well, they weren't hospitalized for COVID. So this study tried to look at were they hospitalized for COVID or not. Here you can see overall 78%, it was determined that it was likely COVID related. That was 76% pre-Delta. During Delta, it was 84%. And it does drop a little bit with Omicron, but still most of the patients who are categorized as hospitalized with COVID are there because of their COVID. One of the other myths that I hear again and again is, well, those are all kids who had something else. They had some sort of underlying condition. They were obese, they had asthma, they had a heart disease. And you can see that that's true for about 70% across the board. Somewhere between 2/3 and 70% of the kids did have an underlying condition, but you can see here that about 30% had no underlying condition. And then how big of a deal? I have to tell you, every kid who's hospitalized, it's a big deal for them and their parents. But you can see that about 20% of these kids did end up in the ICU. So it was higher in pre-Delta than in Delta, dropped a little bit, and the lowest is Omicron, but still about 2 in 10 kids that were hospitalized during the Omicron predominant period required ICU care. And this is another important, I didn't put the data about this in the talk, but you can look at it in the MNW article if you want. 9 in 10 of the kids that were hospitalized were unvaccinated. So I also want to talk about the mortality data. And part of this is sort of a historical interest to me, because I remember I used to work in pandemic planning at CDC, and we would always show the mortality related to the 1918 pandemic, and people would say, well, that won't happen ever again. I mean, we have antibiotics now. We have ways to deal with these infections now. We have better ICUs, and we have better ways. But this really shows that even despite all those advantages that we have, COVID-19 has had pretty significant effects on mortality. So here you can see, this is the data from 2021. These are preliminary data from 2021. Here you can see, so this is 2020, this is 2021, the number of deaths that occurred overall. And then this is the proportion that are COVID-19 related. They did again look at, did they just happen to be in the hospital and sick with something else and then get COVID and die of something else, or were they dying of COVID? They did show that about 90% of them, the COVID was believed to be the underlying cause of death. You know that when you fill out a death certificate, you can put the underlying cause, and then you can add up to 20 other diagnoses. And most of these cases were ones that COVID-19 was believed to be the cause of death. And this, I think, is really telling. We all know heart disease and cancer are major issues in the United States. Coming right after that is COVID-19. So 693,000 deaths from heart disease, 605,000 from cancers, and then 415,000 from COVID-19. And this shows that, in the time when vaccines were available for most of the population, 60,000 people died. And we know that if those people had been vaccinated, many of their deaths could have been prevented. So this is another one of my areas of particular interest is pregnancy. And we had a lot of data early on. Of course, we know from influenza and pertussis vaccines that moms that get those vaccines during pregnancy provide some protection for their infants for the first, somewhere between 5 and 6 months of life. You're less likely to be infected with influenza, a baby in the first 6 months of life, less likely to be infected with pertussis in the first 6 months of life. And we assumed that would be the same for COVID-19. We saw that umbilical cord blood had antibodies from the mom. We know those antibodies, that IgG freely passes across the placenta and can provide some protection to the baby. But we really had to be early on saying might provide protection. I think we're starting to have data now that is pretty convincing. And here you can see if the mom has had her vaccine during her pregnancy, there is a 61% effectiveness against hospitalization for that infant in the first 6 months of life. So I think my hope is that this will be something, of course, moms when they're pregnant are worried about taking Tylenol. So they have, of course, worry about getting their vaccine. But this shows that not only does the vaccine protect them from dying, but can protect their baby from ending up in the hospital. It does look like there's some effect, and these are wide confidence intervals, obviously, but it does look like there's some effect of getting a booster later in pregnancy. So, it does look like if you're getting a late vaccine from 21 weeks gestation through the 14 days before delivery, you need enough time to get that baby vaccinated, get the mom vaccinated a couple weeks before delivery so she can make her antibodies and they can flow across the placenta and protect the baby. But you can see there's a difference between moms that are getting vaccinated in the first 20 weeks versus later. Doesn't mean somebody should wait, but it does mean that if you're waiting to get your booster, it might be best to get your booster after 21 weeks of pregnancy. So we talked about this myocarditis a couple months ago, and I'm not going to go into detail because of that. I think we talked about it in February. There's a paper that's published in JAMA looking at the rates of myocarditis in young people, mostly young men, after COVID-19 vaccination. And I think what we've learned is that there is an increased risk of myocarditis. I don't think there's any question about that. It seems to be a very small increase. And the other thing is that what this data showed is that it's not all ages, and it seems to be primarily in the kind of 12 to 29 year age category, or maybe you could even go to 12 to 39 year age category, that there is an increased risk. But at the highest, it's about 1 in 10 to 1 in 20,000 in that age category. So all along, people have been saying, yeah, but you also get myocarditis from COVID-19. But there hadn't been a head-to-head comparison of these. What's the chance of getting it from COVID-19 versus what's the chance of getting it from the vaccine? This is a paper, it's interesting. This is a paper from PCORNet, which includes some data from One Florida. So One Florida is acknowledged in this paper, but it was able to do that head-to-head comparison. So they used data from 40 healthcare systems, including One Florida, that participated in a large network. They found the risk for cardiac complications. So they looked at myocarditis or pericarditis, or myocarditis, pericarditis, or multisystem inflammatory syndrome in children. And they saw that the risk for problems with your heart were much higher if you got COVID versus if you got COVID-19 vaccines. So if you take the highest risk group, so that's people, males in that 12 to 17-year-old age category. And here you can see, so that I limited this to that group because that's the highest risk group. That group, if you get COVID-19, you're 2 times more likely to, and this is limiting it to the second dose. You can see the first dose, you're 23 times more likely, 18 times more likely in the 7-day or 21-day to get myocarditis. But you can see if you pick this highest age group, 12 to 17-year-olds, highest dose, it seems to be highest after the second dose. The rate seems to be dropping after the booster dose, but you're about twice as likely to get myocarditis after COVID-19 than after the vaccine. So I think that is helpful data for people that are trying to make the decision. One of the things that this did show, and this is from an advisory committee on immunization practices meeting at CDC's advisory committee about vaccinations. They presented these data. I haven't seen these published yet, but I wanted to show you this. It does show that it appears that if you wait longer between the 2 doses of vaccine, that the rate of myocarditis drops. And so here you can see it's less impressive for Pfizer because the rate is lower for Pfizer than it is for Moderna. And these are people who had Pfizer and then Moderna. You can see that if you wait till 8 weeks or more after, that your chances of getting myocarditis is less. And of course, in the early part, when we had high rates or during Omicron, you certainly wouldn't want to say to somebody, wait for 8 weeks because you know that they wouldn't be protected during that time period. But right now, if you have a child that you may be saying, I wanted to put this off because I didn't want to risk myocarditis, I think it's certainly reasonable to wait 8 weeks instead of the typical 4 weeks between the 2 doses. And that is what the CDC guidelines came up with. This was released in February, that small risk, that 1 in 10 to 1 in 20,000 risk of myocarditis in males ages 12 to 39 years, so they went up to the higher age group, might be reduced, and they might even get better antibody responses and vaccine effectiveness with a longer interval, up to 8 weeks between doses. So I wouldn't have suggested that earlier on when we were in the middle of Omicron, but I think right now when we're hopefully at a little bit of a lull for a time, I think that would be a reasonable thing. So that is all that I had to present, and we're happy to answer questions.
Thank you very much, Sonia. And let's see if there's any questions. Thank you for your comment. Well, I see no questions that are coming up, so let me thank Sonia again for all the work that she has put into this and has made this seminar series a success, and wish her the best of luck for her next segment of life. And it's been a real pleasure to work with you, and thanks for your support of the One Health Center and the things we do. So thank you, everyone. The summer semester is here, and we look forward to catching up with you all in the fall. So thank you, and enjoy the rest of the day, and good luck again from all of us to Sonia and to Thomas Bye-bye.
Thank you. Bye-bye.